Dr. Joan Glutch, Division Chief and Professor of Clinical Community Oral Health at Penn Dental Medicine. In this segment, I'll be presenting concepts of dental public health which bring the population perspective to oral health and dental care. Materials previously presented in this course have focused on a wide range of clinical activities that are completed with individual patients in order to promote health, prevent disease, and restore the mouth to proper function. In this section, we'll expand the focus to examine community-based approaches to disease prevention and health promotion in dental public health. Defined as the science and art of preventing, controlling disease, and promoting oral health through organized community efforts, dental public health has been recognized as a core competency for all dental care providers, as well as a dental specialty by the American Dental Association since 1950. Dental public health includes three core competencies: assessment, policy development, and assurance. This illustrates dentistry's dual perspective in providing oral health care for individuals as well as community members. Just as clinical dentists complete a comprehensive examination and determine patients' diagnosis, public health dentists assess community needs through epidemiologic studies and surveys. Just as dentists develop treatment plans and provide clinical care, public health dentists develop and implement oral health policies, educational and clinical programs in order to best meet community needs. After providing care, dentists will evaluate the success of treatment and determine recall intervals. Similarly, public health dental practitioners will assure the effectiveness of programs to monitor community interventions. As an example, fluoridation of community water supplies to reduce dental decay represents one of the most enduring and successful dental health programs. Defined as the adjustment of drinking water to the ideal of 0.7 parts per million, the implementation of community water fluoridation has shown a steady increase throughout the United States since 1940, as identified in the CDC graph, with 74.6% of the United States population able to access fluoridated water. Fluoridation of community water systems is a good dental public health example that includes each of the three core activities of public health dentistry: assessment of the fluoride content of drinking water, as well as periodic assessment of decay rates among both children and adults, are essential components when analyzing community oral health needs. Once the needs are determined, policies are developed and recommended for implementation, such as the policy recommendation of the addition of fluoride to drinking water to reach optimum level of 0.7 parts per million. In order to assure that the policy recommendations are implemented, monitoring measures which involve frequent analysis of fluoride content in drinking water, as well as ready dissemination of the information to all stakeholders, are completed by dental public health practitioners. For example, the Centers for Disease Control and Prevention maintains technical support for water engineers regarding best fluoridation practices, as well as maintains an interactive map on the CDC website, My Water's Fluoride, to identify fluoride content in community water systems in the United States. Assurance activities also include attention to best practices based on research evidence, such as defending water fluoridation based on credible science in reputable professional journals. Examples of other key dental public health programs have included the administration and provision of dental care at community-based and safety net clinics, policies to include dental care and healthcare reform, and assessing program effectiveness of community interventions in reducing dental decay. Although oral health is an essential component of general health, assessment of oral health status in the United States reveals that dental decay, periodontal diseases, and oral cancer remain significant United States health problems. Data from the 2012 National Health and Nutrition Examination Survey, that's NHANES, reveals that 23% of children aged 2 to 5 years had dental decay in their primary teeth. Furthermore, untreated tooth decay in primary teeth was twice as high for Hispanic and non-Hispanic Black children compared to non-Hispanic white children. These trends continue for older children in their permanent teeth, with 17.5% of children aged 5 to 19 with untreated dental decay, and 27.4% of adults aged 20 to 44 with untreated dental decay. Moreover, 47.2% of adults 30 and older experience periodontal disease, which increases with age, and 70.1% of adults 65 and over have periodontal disease. These high disease rates are complicated by lack of access to dental care due to financial and non-financial barriers to care. Many adults lack insurance for dental care, which is not a required service in health insurance plans for adults, and states vary widely in Medicaid coverage for dental services. In 2011, the American Dental Association reported 1/3 of all United States adults, at 33.7%, have no dental insurance, and only 14.2% of children have no dental insurance. For many adults without dental insurance or with limited public dental insurance coverage, the cost of dental care is not affordable given their budgetary constraints, and a reason for the increase in dental visits to hospital emergency departments. In addition, non-financial barriers such as dental fear, limited geographic access to a dentist, maldistribution of dentists in the dental workforce, lack of transportation, and language barriers are frequently cited as obstacles to accessing dental care. Statistics regarding the frequency of dental visits reflect these difficulties. Healthy People 2020 Leading Health Indicator OH7 addresses annual dental visits and documents a decline from 44.5% in 2002 to 42.1% in 2012, which is way below the target goal of 49%. These low numbers of annual dental visits are in contrast to the higher number of visits to healthcare professionals, because 82.1% of U.S. adults and 92.8% of children reported that they had contact with a health professional in the past year. Clearly, we need to look at population-based solutions to increase access to dental care. Health systems that integrate medical and dental care have a greater potential of increasing access to dental care, since patients are already visiting the medical provider, which can also reduce those non-financial barriers to care as well. Although there have been studies to increase funding for dental care services in both public and private insurance sectors, perhaps the most intriguing solution to increase access to dental care has been to add new dental care providers in the workforce in underserved areas. Pioneered by the Alaskan Tribal Consortium in the United States, dental health aid therapists have been employed to provide dental care in rural Alaskan communities and other tribal organizations as a more sustainable solution to address access problems. Much like nurse practitioners, dental therapists work in collaboration with dentists to extend dental care provided. Research has documented positive clinical care outcomes. Recent legislative efforts in Minnesota and Maine have established dental therapists in order to increase the number of dental care providers in areas traditionally underserved by dentistry. However, even though 54 countries worldwide authorize dental therapists as mid-level dental care providers, the dissemination of dental therapists among the United States communities has not been widely embraced and still remains controversial. In summary, dental public health promotes a population-based approach to dental care, which complements clinical dental activities. Dental public health practitioners assess the health of populations, develop policies and programs that promote oral health at the community level, and assure that community programs are effective and meet the needs of the population in order to improve oral health. Dental public health practitioners also analyze the social, cultural, and economic forces that affect oral health care, specifically to address increasing access to dental care, promoting equitable funding for care, as well as assuring that the dental workforce is sufficient to meet the oral health needs of the United States population, with the goal to provide optimum access to oral health for all. Thank you.